So Mary Muhindo is one of our preterm birth initiative fellows from UCSF from 2019. She also began her research career in the infectious disease research collaboration, which is known as the IDRC, which is a joint effort between Makerere University in Kampala, Uganda, and UCSF. Her work primarily identifies the challenges of nurse midwives that they face in delivering high quality care to newborns. And she's been working with global strategies and has conducted a mixed methods research study testing feasibility and acceptability of Ugandan nurse midwives using the global strategies to develop NoviGuide, which is what she'll be presenting on today. It's a mobile health technology for the management of neonatal care. It helps clinicians accurately dose medications, IV fluids, and G feeds for babies who are ill. She's worked with Ugandan experts to align NoviGuide with Ugandan newborn care guidelines and has brought the nurse midwives abroad for additional training. And we're really so excited that you could join us today and glad that the internet forces have aligned to let you be here. With that, I'll let you take over.
Thank you so much, Teresa. Hi, everyone. Yeah, I can see people here that I would like to greet. Liz, the two Lizes, and Sloan and Josh. Hi. Yeah. Okay, so I'm so honored to be here, and thank you so much for inviting us to talk. Please allow me to share my screen. And okay, I hope you can see it, and please allow me to stop my video because I do not want to interfere with the internet connection. Okay. Okay, then we will dive right in. So I'm talking about the NoviGuide in Eastern Uganda. And so just to whet your appetite, I would like to share two quotes from our focus group discussions from midwives, and then I'll go into the background and then all the other studies that we conducted. So one midwife says, most of the dosing, I didn't know. So she's talking about the neonatal dosing, and even the choice of drug to be used on the baby, I couldn't know very much. But right now, at least, when I get a baby, I really know that I have to handle using it. So using NoviGuide. So another midwife also says, we have greatly improved newborn care. We have greatly reduced referrals, especially as you hear the midwives confessing. People used to fear when they see a baby convulsing there with seizures. They would rather send to Mbale, send to Mbale. So Mbale is our regional referral hospital. So they would usually send these babies to Mbale. So she continues, they would send them to Mbale because of fear of not knowing what to do for that baby. But now they have a lot of courage. Even if the baby is convulsing, they are not worried. They just get the tablet, fill in whatever they are going to fill, and they give the medication accordingly, thanks to the developers of NoviGuide. And Dr. Josh, the developer of NoviGuide, is around, and I would really let you know that the midwives are really impressed about NoviGuide. So why do we care? I mean, why do they love NoviGuide so much? And why are we so interested in the midwives using NoviGuide? So 2.4 million newborns died in 2019, and the majority of these deaths occurred in the low and middle income countries. And our neonatal mortality rate has stagnated at 27 deaths per 1,000 live births in the last 10 years. And of course, this is even worse in rural settings like where I work. And the main barrier is because of the heavy workload that the midwives have. And in my settings, midwives are the main care providers. So in addition to providing newborn care, they also conduct deliveries, they train nursing students, they care for all these other postnatal mothers. So it's really a lot of work for them. They lack confidence and the skills, like you have seen in the quotes. And because of that, they do not adhere well to the neonatal guidelines. So just training them is not enough because these learned skills are normally lost if there's no reinforcement, and the calculations for newborns are really complicated. So you need a calculator, you have to have these weight-based calculations, which usually result into medical errors. and you train staff that actually get transferred to another unit. So you really have to keep retraining, which is not sustainable. So I brought these pictures up so that you can see the difference between neonatal care in the different settings. So on the extreme left, you can see the high-end neonatal care with all these neonatal specialists. So as seen in high-income countries and some hospitals in Kampala. And then, so we go down to the middle, our regional referral hospital that the other previous nurse referred to in Mbale really looks like this. So you see very many babies stuck together because midwives would always just refer them there. So the regional referral hospitals are overwhelmed with patients. And now on the right is a typical district hospital. So in Tororo, we had only 4 beds in this unit where newborns were cared for. And of course, this is really non-existent in the lower level facilities like the health center for hospitals. And I believe in the US, yes, we have those on the extreme left, but in the rural areas, we could be having a picture like that in a district hospital. So how has NoviGuide empowered midwives to provide high quality newborn care in Eastern Uganda? So NoviGuide, you may be wondering why is she talking about NoviGuide? So NoviGuide is a tablet-based clinical decision support software that was designed by Dr. Josh from Global Strategies, really to make a midwife's work very easy. So it transforms national guidelines into very easy to follow step-by-step bedside clinical guidance. So we studied its use among midwives in 2017 in that district hospital picture that you saw on the right. And we wanted to know if the midwives loved it, if they thought it was feasible to use in a district hospital. So we got tremendous results and very nice results because they said it saved time, prevented mistakes, the tool was so usable, and above all, it improved their knowledge and confidence to care for newborns. So these are some of the quotes that they say during the focus group discussions. So one says, the NoviGuide has improved the care of newborns. Me, I could go for paracetamol in case of high temperature, but NoviGuide tells me what to do. And in my assessments of this baby, it guides me to be systematic, and it takes me directly to the medication to give. Like in convulsions, I used to give diazepam, which would instead suppress the baby's condition. But this time, I'm aware that I will give phenobarbital, and NoviGuide even tells me how to follow this baby and the dosing of the phenobarbital. Yeah, and she's indeed grateful for NoviGuide. So another midwife also said, NoviGuide has helped me in the treatment of babies because before we could not know even the doses. We first go and pick the phone, we calculate the dose. It has also helped to save our time and to work on more babies than those days. So and another said, if I looked at a baby that with severe birth asphyxia, I would not manage to let them survive. But now it's better because at first we would just get a gas go, put on oxygen, but you're not thinking of dextrose. You don't think of maybe to start on antibiotics because you're only looking at the breathing of the baby. So more pictures here to show how NoviGuide was being used in the hospital. So the midwives would use them during the initial admission of a baby, during rounding. And one thing that came in handy for especially first-time mothers, they loved those breastfeeding videos that the midwives would just give them, and they, you know, instead of waiting and trying to explain to a mother how to attach the baby on the breast, they will just watch the videos and everything will be covered. Yeah. So NoviGuide is fantastic, but then how can we introduce it into new clinical sites? So we were like, okay, it's of course not cost effective to have Dr. Joshua come over to all these rural areas and train all the midwives. We were like, how about if we train some midwives as NoviGuide trainers so that they'll be able to train their colleagues? So this study, we conducted another study in 2020 where we got 2 midwives supervisors, Sister TM and Sister Beatrice. whom we trained. And of course, while everyone else was still in lockdown in September 2020, we were very busy trying to roll out the NoviGuide the second time. So when we trained them, this is myself and Sister Daisy, who was my research assistant. She's a retired midwife. We conducted this training while the Global Strategies team attended online. So we were there trying to listen to Josh maybe. So it was a 3-day training where the first day was really telling them about NoviGuide and their expectations as trainers. And then the next 2 days were really to train them on how to train them as trainers. So this was on day 2, and then this was on day 3. So after the training, we allowed them to now train their colleagues. So this is a training that was conducted at Toro District Hospital. And this is Sister Team trying to train the other midwives on how to use the NoviGuide and, switching on, switching off, how to log in and how to enter cases into the NoviGuide. So the trainings at the different facilities were done in various ways. So some were done under trees, like in Mukuju Health Center 4, and then at Mulanda, we conducted the trainings in the patient waiting area. So they were really flexible in ways that were really acceptable to the midwives. So some were also conducted on the bedside, like this in Nagongera Health Center 4. We conducted in the maternity unit because they don't have a neonatal unit and babies are admitted with the mothers on the maternity unit. So these are the midwives, the sister team trying to demonstrate a case entry. And in Mukuju, this was a baby who was delivered, and a few hours, this baby started convulsing, as you can even see the back, the arched back. Really had really classic signs of meningitis on a delivery bed. So this is a delivery bed, and they were practicing on how to enter this baby into the NoviGuide. So when we asked them how they felt about the whole training model, having midwife supervisors trained and NoviGuide trainers training them. So one of the trainers said, I also feel very comfortable training my colleagues. These are people we interact with every day, and I think they have confidence in us when we train them. Other than people coming from California, we have different accents, but for us, we're very clear with them. We use simple English, which they all understand. So the other participants also said that training was so interesting. There was a lot of laughter. Why? Because these were colleagues whom we were used to. They were giving examples, a lot of examples, which we know on the ward to train us. And when somebody is giving examples which you know about, things move on well. And being that we are used to them, we are always with them. We saw everything moving smoothly. They were not talking about something strange from nowhere. And then one said, the trainer helped me. She reminded me of what to put as a password and then how to use the other NoviGuide features. So it was really nice. The midwives learned how to use NoviGuide just by being trained by the the NoviGuide trainers. So one said, before NoviGuide, assessing babies would be hard. We are not so sure. So we wait for the doctor to reassess, right treatment and everything. So nowadays, it saves our doctor's time. It's now our work to make sure that we do everything as per the tablets. So we are reducing on neonatal deaths. I highlighted those so that you can be able to see what impact NoviGuide is doing here. I also, one other participant said, I also appreciate the use of NoviGuide. Before we used to refer so many babies, like babies with jaundice, even if it was something you could manage, even convulsions, it was hard for us to manage. But at the moment, at least I can manage at ease with the use of NoviGuide. I normally read out these quotes laughing because these are real testimonies. And of course, the cherry on top is we are able to see how NoviGuide is being used. So one fantastic thing about NoviGuide is it's able to tell you who is using NoviGuide, when and how and by whom and by what. So, so far to date, we have entered over 2,000 assessments into the NoviGuide since we rolled out in September. Oh, and I forgot to mention that that we are at 4 different sites. So 1 district hospital and 3 health center for facilities. So for example, here in Toro District Hospital, so far about 1,153 assessments have been entered for this particular facility. So we are able to know which of these births are initial assessments, which are those are babies more than 24 hours, which one of those were roundings, spot checks, discharges. We are able to know the different entries per month. And then of course, danger points, like for example, if you're seeing very many entries of birth asphyxia, is there something you need to do? Maybe retrain midwives. So those are things that the administrators of the hospital can actually look into and make good use of this data. So the fantastic data collected by NoviGuide is what makes it really an excellent tool. So we nurses really love NoviGuide. It's able to show us all the things we want to see. But then can NoviGuide do more than just providing care? So we were like, how about if we test out NoviGuide's ability to help in the rollout of equipment? So I'm thinking about like pulse oximeters, glucometers, bilirubin testing, phototherapy machines, mechanical ventilation. Of course, some of these are like dreams for rural hospitals, but we started with pulse oximeters because those are very easy to use and they require very minimal training. And normally when a new equipment is introduced at the site, the staff need training, the equipment is left at the site. But the challenges are the trained nurses normally get transferred. You need to retrain those that are there. And when you leave your equipment there, you're not even sure whether the equipment is being used at all or even appropriately. So NoviGuide is able to update equipment, of course, in addition to it providing care according to the neonatal guidelines. You're able to add and edit users. It's able to update the equipment at the side. So when a trainer or an administrator logs in, this is how the screen will be like. And when they click on that button, this is what they get. So all the different equipment that could be available at the facility. And when, for example, for this study, when you click pulse oximeter, this is the question you get. What's the status of your pulse oximeter? So when we provided the initial training and the pulse oximeters, we clicked in working order and we were able to now see that particular question about pulse oximeters added to the usual guidance that NoviGuide gives. So specifically to ask you, as you're doing your assessment, whether rounding or you're admitting a baby, to ask you what's the baby's oxygen sat level. And then you go ahead, measure it, and then enter in here. So, and as it's being used, it will definitely show you how the pulse oximeter or any other equipment is being used. So for example, for pulse oximeters at the main hospital, we introduced it in May. And as you can see, this blue line, it started going up. So showing that the midwives at that facility are actually using it. Okay, so what more? What next? So we are now thinking broadly and widely. We're like, okay, how about if we put NoviGuide at so many other sites, like 30 hospitals? So we're working on this and we're thinking of putting maybe in central and western Uganda. We would also like to find out if NoviGuide can ease referrals of newborns and if NoviGuide use can help with the management of inventories, because with our data showed us that there's a lot of drug stockouts, especially for ampicillin, gentamicin, really essential drugs for newborn care. Can NoviGuide help manage that? So those are things that will be in our next talk, if we talk next year. So we would like to thank the administrators and the midwives at these different facilities, and of course IDRC and Global Strategies that developed the tool, and Preterm Birth Initiative that sponsored this work from the very beginning and even during my fellowship. Yeah, thank you so much for listening.
Mary, is it okay if we open up to questions?
Yes, please go ahead.
Well, I can start. One of the questions I had is, and you might have mentioned this and I missed it, is the app need to be connected to the internet, or are all of those features available offline as well for some of the more rural districts that might not have connectivity?
Yeah, thank you. That's an excellent question. So yes, the app is available on the tablet and can be used off or online. And for this study, we provided modems that were providing the internet that would always be switched on and off anytime they needed to sync the data.
Hi, Mary. I was wondering, and sorry if I missed this too, but is there a process in place for updating the information as like guidelines change over years?
Yeah, so that's the goodness about NoviGuide, because without it, you will need to go and send experts to each district and retrain the nurses if there's any change in the guidelines. But all you need to do with this is just click a button and the NoviGuide will be updated. But Josh can give us something more, but that is the goodness of NoviGuide.
Oh, Mary's description is right. That's right. You can just send updates when you sync.
And sorry, Michelle, go ahead.
Oh, I was just going to thank you. That was such a great talk. I maybe others know like the history behind this app, but I was just wanting to hear more about sort of like the origin of this project and how you all got the idea, and also what are your plans to increase uptake of this perhaps in other areas of Uganda, or and also does the app include anything about anything malaria related, like for example, like IPTI, or I guess those are mainly in trials. It isn't yet policy, so maybe not.
Josh, would you like to take that up?
Sure, I can add a little bit. So the NoviGuide started basically by trying to make it easier to follow the guidelines. As Mary correctly reported, it used drug dose calculations as a hook to get people to adopt it. The NoviGuide is a broader platform, so there's nothing that prevents it from adding new content or any new pathways as it relates to malaria. Where Mary has been so instrumental, maybe I'll pitch it back to her, is in testing not just the app, but the training and the what we call the surround. So maybe Mary, from your own experience, I'll throw a question to you is, I've been there when we trained and I've seen Ugandan midwives train. In my mind, it's so clear that Ugandan midwives are better, but can you tell me, is that your opinion and why do you think they're better?
They are definitely better because there was a quote that I looked for that I couldn't find in our focus group discussion that was really specific on how midwives actually use the local language to explain how to use the NoviGuide. So in addition to using that simple English, they actually go into Luganda or Japadola and explain to these midwives, so they really understand it at their level. And the midwives being around all the time, they know these nurses, the midwives, they are able to, they interact with each other on a regular basis. They are not afraid. For example, if Dr. Josh came, you will need time to really understand him at that level and to maybe hear what he's saying. But this came so organically, and they were able to understand everything that the trainers were able to tell them.
There's a question in the chat actually from Goldie Mazia, who's from Save the Children, and she'd like to share your presentation, Mary and Josh, with your permission. So I can, I think if that's okay with you, I can, we'll distribute the YouTube channel where it's available, because that's how we will be posting it.
Yes, it's okay.
So I'm going to be selfish. Oh, Teresa, can I ask a quick question?
Sure, Elizabeth, and then Sonia.
Oh, so sorry. Well, I'm going to be selfish because I think it's really, first of all, super interesting and really critically important to have done the work, Mary, that you've done in terms of understanding uptake of anything before you can understand some of the other metrics that maybe Save the Children and Global Strategies are also interested in, which are sort of true outcome measures for the babies, because without the uptake, how can we ever get to the outcomes? But I am curious about, what are the outcomes, Mary, you think we should be measuring next with global strategies in terms of on the ground? What are the relevant and meaningful outcomes that you think we should be next focusing on?
Thank you so much, Liz. So, of course, just by observation alone. So before NoviGuide, just a walk into maternity, we would just see babies dead in their mother's arms or dead in the warmers, because the midwives would always wait for the doctor, like one of the nurses indicated. They would wait for the doctor to reassess, write something, and we would always follow. But the doctor is very busy and is only one on the ward. So they would not be available to do, to care for all these babies. So with NoviGuide, they were able to have that confidence and the courage to care for this baby, and of course, in addition to the skills and the knowledge. So that reduced on neonatal deaths. That would be, of course, a very good indicator to follow up. But since it's a rare occurrence, now with Save the Children, we want to look at if it actually reduces referrals. From just the midwives conversation with the midwives in the focus group discussions, referrals have greatly reduced from the district hospital to the Mbale Regional Referral Hospital. But even when we put NoviGuide at a lower facility in the health center 4 levels, the nurses at that district hospital are like, we no longer hear about babies being referred from this health center for facility. And even when we talk to the midwives at the health center for facility, they're like, no one can talk that we have been referring our babies. They only refer the very, very sick ones that really need like specialized care that they are not able to prefer. But simple conditions like sepsis, like jaundice, they are able to care for, or even just the D10, they are able to provide. And that's thanks to NoviGuide. So yeah, back to your question. Yeah, it will be, how has NoviGuide, of course, using numbers, how has NoviGuide reduced neonatal deaths or neonatal referrals? Those will be our next steps. And you're right, we can't go that far before we know how the midwives love the NoviGuide. Do they love it? Are they able to use it? Is it a usable tool? And that now we know.
Sonia?
Great, thank you so much for this presentation. I was really curious about the slide where you showed about the asphyxia rate being like 10% or being high, and if things like that have stimulated the midwives to like ideas, or if there have been initiatives based on some of the data you've gotten from the NoviGuide that have been within the within the hospital, or if you could speak more about how that's used.
Yes, thanks. That's a good question. So NoviGuide, in addition to providing this assisted care and excellent guidance, we are able to use its data. So we've shown this data to the hospital administrators. Firstly, in terms of the several stockout levels that have been reported by the midwives. So we asked them, is it true that these drugs are actually out of stock? Then they tell us what they think. And then, of course, the conditions. If you're seeing very many babies born with birth asphyxia, do we need to retrain these midwives on how to do excellent obstetric care? So that is the usefulness of NoviGuide, and indeed the hospital administrators have seen its capacity. So and the district hospital did not have a neonatal unit, but from the very first study, when we showed them how much the NoviGuide was being used by the midwives and how many newborns were actually cared for, they were like, oh no, we need to have a specialized space, at least where we can have beds and these babies admitted. So that's how NoviGuide data can actually improve newborn care if it's put in the right hands, like the hospital administrators, the district health officers, and all these Ministry of Health officials.
I'll throw out another question. What do parents ever see it? And what do they say?
Oh yeah, so Liz mentioned that one other thing that we would urge to check would probably be to ask the mothers how they feel having their baby being cared for using NoviGuide. So just by looking at them from these previous studies, the mothers are so excited. So like in that picture that you saw, of course, it's this first-time mother, probably in her late teens, because our mothers really deliver very early. And the lady just lying beside her was her mother, like the grandmother of the baby. So they were all watching these videos with interest and, you know, amazement. You mean this tool actually exists? So they love it. They love it being cared for. And I think it also increases their confidence in the midwives, because they now know that the midwives are doing the right thing. And there's this saying that we had in the focus group discussions, that the midwives, the mothers are now coming more with sick babies instead of going to the traditional healers, because in the main hospital, we enter babies in computers. So that has increased the referrals in from the community and of course, the confidence of the community in the midwives caring for newborns.
Hi, Mary and Josh. Thanks for this presentation. Thanks, Josh, for your previous presentation last week. I am wondering, so I think NoviGuide is more like post-resuscitation use. Is there any consideration to kind of making sure that the neonatal resuscitation itself is improved? I'm not sure if that's something that you guys are concerned about, or you know, if that's something that could be helpful.
Yeah, you've already peeped into the software. So the software has three main sections. So the first one is the decision support part. And then the next one is the resources that the midwives use. But the other one, to answer your question, is the resuscitation video that the midwives can always look at to remind themselves of those, you know, skills that they need when they get a baby that requires any kind of resuscitation. So that is catered for in the software.
And hi, that was a wonderful presentation. I also had a quick question about feedback from the midwives and how often you're able to get feedback so you can make adjustments in the software and improvement in the software.
Okay, fantastic. That's a good question. So before we rolled out the NoviGuide, it was reviewed by experts from the Newborn Steering Committee, and we wanted to make sure that the content in the NoviGuide actually aligns with the Ugandan clinical guidelines. So they reviewed it, they okayed it, made a few adjustments. It was improved by Josh and his team. They were like, this is what we need in our rural setting. So that's when we rolled it out. And during the study, we've not had any recommendations from the midwives that anything is missing or anything needs to be added. So that actually confirms that the NoviGuide is fantastic. To get feedback about like how the NoviGuide is being used, that data is collected on it's synced onto a Wi-Fi every 3 to 7 days. So we are able to know how the midwives are using it, who is using it, when it's being used, and on whom.
Is there something you learned about midwives that you didn't know before this project that now you know? I mean, as you're working with them in like such a different way, and some of this is like training on software, not training on midwifery. Is there something you learned about them?
Yeah, so before my background was in malaria in pregnancy and in newborns. So we used to have these birth cohorts where we will enroll our mothers, put them on these, you know, drugs and follow them up until delivery, and then have their babies delivered. But then I noticed that when we have like a sick newborn and we admit in the hospital, the baby would always be referred to Mbale. I mean, a baby that would have been cared for. So we train. And then as you train them, you realize your trained staff has actually been taken. So that is how I got into NoviGuide, through Dr. Theodori Raoul, who is my mentor. And he was like, I know a guy who made the NoviGuide, we can try this out. So that is how this whole study things came. But back to the question. So these midwives were so incompetent. They were so afraid. Every time a sick baby would come, or even unobstructed delivery, or anything that would indicate that the baby may need care, they would be like, oh my goodness, just refer. But then with NoviGuide, they were now able to care for these newborns. Their confidence really improved. Even for midwives that didn't have like smartphones, there are these little phones that we call kaviriti here, the non-digital ones. So many midwives had them, but they were able to adjust so quickly on how to use a smartphone and, technology, and that excitement they had, they have that we are now able to use technology to improve our care. So I've seen them improve from just being, of course, fantastic midwives, but with little confidence, to really now very excellent midwives with added, technical advantages.
I have kind of a follow-up question on that. You mentioned the high turnover among midwives. Do you think the NoviGuide, I know it hasn't been in use that long, but do you think it will, or has it had any effect on the turnover or the midwives' desire to stay at a site?
Yeah, that's a good point. So that staff turnover or the transfers are actually beyond their control. It's a normal thing that the ministry does to make sure that all midwives are exposed in all the different levels of obstetric care or gynecological care. So one year they will be working in the antenatal unit, another year they will be transferred to the postnatal unit, and sometimes referred to the pediatric unit. So those are normal transfers that are done. But you see, it's normal, but then it affects care, like in a unit, for example, newborn care, which is very sensitive. You need those weight-based calculations, which are really tedious and annoying. And then you also need like skills to care for a newborn. And in addition to, you're conducting a delivery and you suddenly have to switch to care for a newborn that needs care, that is work. So with NoviGuide, that really eased their work. They were able to transition very quickly, without really having struggles. And even when you have a midwife who has been maybe in the antenatal unit for like 3 years, by the time they come over to the maternity postnatal unit where newborns are admitted, you just train them for a very short time, because it's a very usable tool, very fantastic tool. You don't need days to learn how to use it. You can adjust from palpating distended pregnant women to now caring for newborns. So that is what we are looking at. So when we think about the scalability of NoviGuide, can it be done locally? Can we have these midwives trained as nurse trainer and NoviGuide trainers, so that every time these staff transfers happen, a midwife can easily adjust from, antenatal to now neonatal, from pediatrics to now neonatal. So that is what we're trying to prove in this current study, and the studies, the next study that we hope to work with the Save the Children.
There's a question in the chat from Sarah Williams. And actually, Sarah, I'm going to ask you to come off mute because I'm actually not familiar with CHI. So it would be helpful if you could ask your question directly.
Sorry, my name's Sarah Williams. I work for Save the Children as well. I was just wondering, and I do sometimes get my acronyms wrong, forgive me if I have. So a lot of government systems, they collect their data centrally using something called DHIS2. And I know that there's been talk about some tools and things collecting data that links seamlessly somehow with DHIS2. So if you have a stillbirth, or if you have a baby that requires asphyxiation, anything that's reported in DHIS2, is there some way in which the NoviGuide links that? And then I did have another question, which I just wanted to know about the use on phones. And I saw the tablets and things, which is great. And I was wondering if nurses and midwives also sometimes use their own phones, and how well does that work? Yes, but no, it just sounds so brilliant. So it's so good to hear about it. Thank you.
Okay, thank you so much, Sarah. So the NoviGuide was uploaded onto tablets, and they are not privately owned tablets. So they are owned by the hospital and placed at these units. So they are not on individual private phones. And so even when we have like transfers, the tablets do not go anywhere. They just remain in the maternity unit. So your first question about whether it's linked to any data source. Currently not, but that is something that we can look into because the NoviGuide is already providing so much data that can be very useful to the hospital administrators, Ministry of Health, and international organizations that are interested in improving newborn care in rural settings.
Thank you. Sounds great.
One thing I've learned from Mary is this distinction between confidence and knowledge. It's like such a huge part of this. And as we have residents here on the call, it's like there are probably many residents who have knowledge about neonatal resuscitation, but not confidence, or similar for like a lumbar puncture or other procedures. Mary, can you talk about that and how it's influenced how you look at other digital health studies that you review and other projects?
Yeah, thank you so much, Josh. Yes, confidence and knowledge are sisters. In fact, twins, they move hand in hand. So you cannot have most of us were trained in medical school on how to care for newborns. But then when you're into the field, you're given a sick baby. Where do you start from there? So that was the main problem with the midwives, especially in rural settings where newborns may be fewer than expected compared to high volume centers where you keep seeing this thing and you keep doing it over and over again and it becomes part of you. So that is why NoviGuide is really important in these areas where there are few newborns. But with NoviGuide, of course, the midwives improve their knowledge and confidence. And one thing that came out also so vividly in the focus group discussions is like, of course, in addition to saving the doctors' time, these doctors also feared to care for these newborns because they are busy conducting cesarean sections, doing administrative work. And now you're giving me a convulsing baby. Okay, where do I start from? We are trained. Yes, I'm a doctor. I'm trained in these things. But if I'm not seeing it so frequently, I'll definitely forget. So they loved it as doctors because that was now off their to-do list. The midwives had sorted it and they were doing it so well. So it's a two-pronged tool helping midwives, but also helping the other health professionals, the doctors and the clinical officers. So one stubborn midwife was like, okay, if the doctor writes the medication, let me check and confirm if they're actually true. So they would look at the prescriptions and then do a similar entry into the NoviGuide, and there were obvious differences in the dosages. So yeah, they were like, you need to train the doctors also on how to use the NoviGuide. Yeah.
Can I ask a question about this is based on the national guidelines from the Ministry of Health. How I guess what's the relationship like, or how involved is the Ministry of Health both in the app development as well as the updating of the guidelines? Because I imagine that you clearly want to work very closely together to make sure that you have the most up-to-date guidelines. How has that worked actually on a practical level?
So from those initial phases where we're involving that team, they reviewed the NoviGuide to make sure it aligns with the current guidelines. And the guidelines rarely get revised. I think since we started in 2017, we've not had any revision. We've not had about any revisions. Maybe they're there. We can always find out, but they have not changed at all. And so it's still in line with the guidelines. So our next plans is, of course, to share our results with the Ministry of Health officials to let them know how it's transformed newborn care in rural settings, how the midwives love it, and how it has the potential to reduce neonatal mortality in our settings. Yeah, so we hope to engage with them so that they are able to know how we're doing.
And as a follow-up question, how have they been supportive so far, or interested? I guess what's the level of engagement been, or is the goal to bring them the data and show them how good this is, and hope that they'll support a broader implementation?
So our key stakeholders are the district health officers that have really been supportive, and the hospital administrators that have been encouraging these midwives to to use the NoviGuide, and also making sure that all the data is available for them to use. So they always ask for updates. How is it going? And one of the Sister Connie, our deputy district health officer, did not know about NoviGuide. So she just realized that the data for newborn deaths had actually gone down. So, and she was really surprised. How? In a district hospital? What are they doing? So when she came down to the ground, I actually told her, we have something, we have a computer that has really improved our newborn care. And, you know, from then she started asking many questions and was always very eager to know what is going on. So our plans, of course, is also to inform the Ministry of Health officials. From the last time we talked, we had not yet shared our data with them. But of course, they've been supportive from the beginning, but we are yet to share our data and everything that we have found in this study.
Hi, Mary. Thank you so much for your presentation. I think you might have alluded to this already, but in thinking about the transport of the very sick newborns that go from the district hospital to like the next step referral center, has NoviGuide, it sounds like it might be staying in the district hospitals for now. Has there been any thought in sort of applying it to like that period of transfer? I'm not sure how far the babies have to go. I'm sure it varies from site to site. Just curious a little bit about that.
That's a good point. So our regional referral hospital is about a 45 minutes drive from the district hospital. That's quite far for a baby that really needs care. So even for conditions that these midwives are unable to care for, they first give that treatment, you know, the dextrose, and make sure that the oxygen sat level is okay. Maybe we need to keep them a little longer for them to get oxygen, or maybe we need to start antibiotics. So they do that, and when they see the baby is safe enough to travel, then they are ferried to the referral hospital. But of course, there are challenges. Going to a new district where you don't even know the language, looking at our, local women, the mothers, the majority of our patients, or mothers of our patients, are really non-English speakers and poor. They may not be able to have the money to move over to the other side. In fact, the majority of them are like, Musawa, just treat me from here. I'm not going anywhere. So, but those that are able to go, they go. And when they come back, they tell us stories. The place was crowded. We slept on the floor, because everyone refers their babies there. So there needs to be something. And the referral district hospitals have a neonatologist with, of course, nurses. It's where, okay, despite the numbers, they are able to do that high quality care, but they get overwhelmed because you cannot treat all newborns in Eastern Uganda in just one little facility. You saw how crowded they are. So equipping midwives in these lower health facilities, district hospitals, the health center 4s, the health center 3s, where deliveries are conducted, is so crucial for us to provide high quality care. So I was in one of these health center 4s hospital, and the baby was convulsing, could not respond to phenobarbital. No, they were not able to afford, they didn't have access to phenobarbital, and we could only find it in a district hospital. So the lady was like, how am I going to travel? Fortunately, we were there. We came over with her to the district hospital. Now imagine all those that we are not able to know about. They end up going home and, having their babies dead for a condition that could actually be preventable. So that is why we would advocate to have NoviGuide in all these lower health facilities, so that the regional referral hospitals only concentrate on the major rare conditions, the congenital anomalies, and all these big things that district level or lower level hospitals cannot care for. And especially during this COVID time, I mean, you can't have a crowded unit with all the SOPs that need to be followed, with mothers sleeping under beds of the newborns, really. Yeah, so yeah. I hope I answered your question.
Mary, I should have asked this at the beginning, but can you remind us what midwifery training involves? Like how many years, what the skill set is? Because I know that it's different from registered nurses, but I actually don't know how those skill sets are different, or the training and how they might overlap or be unique.
Well, I may, may not be the right person to answer that, but from my little knowledge, they do midwifery, I think specifically, and then I'm not sure how long it is, 3 or 4 years, but maybe if there are midwives on the platform, they can be able to share. But there are those who, what they say, are double trained. So they come as ordinary nurses and then they go over to advance as midwives. So midwifery is like a specialized unit that they only concentrate on, you know, obstetrics and gynecology and newborn care. But I stand to be corrected.
Thanks, Mary.
One more question. Has any of the midwives been pushing for this to be translated into obstetric care or interested in that?
Well, yes. So when they are in their usual monthly meetings, the midwives on the neonatal side are always shining because they have all their data available. You know, how many babies they've admitted, how many they have referrals they have prevented. You know, they are so organized. And one of the midwives working in the antenatal unit was like, but you know, before a baby is born, the mother has to go through our hands. How about if you provide these videos for us to share to the mothers while they are still pregnant? For example, the breastfeeding videos, the danger sign videos. How about if we show them before they actually come when it's too late at your side? So I've already told Josh about that and we will see what to do, but they are really interested because they are different units. So the ones who are working on the postnatal side only get rotated after a year to the antenatal side. So they do not like work together. So they only hear about NoviGuide on the other side and they're like, we also need it on our side. Yeah, so there's great interest.
Josh, time to get to work. We need another one.
I'll just throw out there maternal fever. That's a target we're looking at really closely. I actually applied for a grant to maternal fever and got this feedback. This is a niche topic. I was like, really? I don't think so. So we're going to be looking at maternal fever because it flows so nicely into what we already know how to do with the dosing. In fact, same medications. And so that's one. Preterm rupture membranes, betamethasone. There's a lot of great targets out there. So yep, stay tuned.
And are you familiar with the work that Dilys Walker is doing as well? She might be a good potential partner if you ever get to the stage where you're doing, she does a lot of simulation. I think she does neonatal resuscitation as well as like postpartum hemorrhage, but her work is mainly in simulation based.
Yes, I really admire her. She's one of my inspirations, and she was my boss during the fellowship. So I know about the Pronto. I know everything that they're doing in East Africa for the preterm birth initiative, and those are really motivations for us.
I think we have time
Yes,
for maybe one more question. Sorry, did someone? Becca, sorry, did you have a question? Okay. I think we have time for one more question if anyone wants to put it in the chat or come off mute, and then I'll put the session evaluation link in the chat. We really appreciate getting feedback. It is a very short evaluation, I promise. It's like 2 questions, and we do really value your feedback. I think we have time, like I said, for one final question. Okay. Thank you so much, Mary, for joining us, and Josh. It's wonderful to hear about the incredible work that you're doing. It's really inspiring. And I'm so glad that the rains allowed you to connect with us today so we could hear about it.
Oh
if
yeah, thank you.
If you have additional questions or want to reach out, what's the best way to contact you? Do you want them to go through I saw there's a website for NoviGuide that I can put a link in the chat, or if you prefer to be contacted a different way.
You can just email Mary, I think, if there's any questions about the work in Uganda.
Yeah, definitely. I'll be very happy to answer any questions. And thank you so much for having us here. And it's always a pleasure to share about our work because we've seen how transformative it's been. Yeah, thank you so much. And I wish you the best in your next endeavors.
Thank you very much.